Welcome to today's webcast, Reimagining Law Firm Benefits. And a special thank you to today's sponsor, Acrisure. We are excited to be joined by Reed Middleton and Paul Siegert. Reed is an executive vice president at Acrisure, previously Ahern Insurance Brokerage. He is a California licensed attorney and insurance advisor with extensive business and legal expertise in employee benefits programs, business succession planning, and overall risk management. Prior to joining Acrisure, from 1995 through 1998, Reed served as a in-house counsel to USD Healthcare, where he advised physician groups and hospital systems as to insurance reimbursement, capitation and risk pools, managed care, and employee benefits programs. From 1998 through 2001, he served as senior corporate counsel to Alaris Medical Systems, a 550 million publicly traded medical device and software company with 2,500 employees doing business in 120 countries. From 2001 through 2004, he served as general counsel and secretary for the Upper Deck Company, one of the largest sports and entertainment publishing companies in the world. Following his experience at the Upper Deck Company, Reed founded an employee benefits practice group providing benefit planning and insurance guidance to a wide range of businesses from leading technology providers to law firms. Reed holds a Bachelor of Arts degree from the University of California at Santa Barbara and a Juris Doctor from the University of San Diego School of Law, where he was a member of the San Diego Law Review and served as its lead articles editor. He holds life, health, and property casualty licenses in several states and is a registered representative offering securities through Crown Capital Securities LP. He is also a published author and a member of the California San Diego Bar Associations. Paul Siegert. After serving as a Russian intelligence analyst, Paul became a growth leader for a national insurance company. 5 years later, he left to fix the healthcare payment model, and his firm grew rapidly. At the request of others, Paul started a marketing company that white labels his sales and marketing systems throughout the U.S. In 2021, his companies joined the Acrisure brand. Paul regularly appears in the media, including Wharton Business Daily, CBS, NBC, ABC, Fox, Newsmax, Cheddar TV, The Wall Street Journal, and he is also co-authored the recently released book, Benefits Revolution, The Next Generation of Employer-Sponsored Healthcare. Paul is a father of 5 and a student pilot, so he can work and still be home in time for dinner. Thank you. And now, Reed, I will turn it over to you.
Thank you very much. Let me just share my screen. So thanks everyone for joining us. Reed Middleton, as you know, from Acrisure. It's funny listening to those bios. It does seem to take these days a former intelligence officer and a recovering lawyer to sort out this healthcare mess. So what we're going to talk about today, obviously, is reimagining the law firm benefits and how we deliver healthcare to our employees. One of the key things we need to focus on is cost, is what's going on in the marketplace, the healthcare market, and what factors are driving those costs up. We're very excited to share our thoughts with you and some of our recommended strategies. So I'm going to go through for the next 20 minutes or so and really talk about the marketplace and the accelerants in terms of cost and what's driving those things. And then we'll talk about some of the strategies you can use, some of the strategies firms are currently using, and how we go beyond that and start building out some custom solutions that really not only lower that cost curve, but really even more importantly, how do we deliver a better experience and really a better benefit package to our employees in a sustainable manner over the long term. So as you can see here on the screen, Howard Schultz famously said, Starbucks spends more on healthcare than coffee. And it's pretty staggering to think that the average employer, average business is spending around 16,000 per employee per year on healthcare. Considering the average business in the US size is under 10 employees, this is an enormous number, and likely exceeds for some profits per employee. So it is a daunting task. There are some headwinds for sure. But again, the good news is there are things you can do about it. And we're gonna talk to those here in a few minutes. We do believe we have a great healthcare system. We just have a terrible way of paying for it. So national health expenditure growth is set to exceed our gross domestic product growth by 2031. Private health insurance, about 30% of our national health spend, and RX, with pharmacy components, really contributing significantly to that. And some of this is, related to COVID, post-COVID, great resignation, lots of nurses leaving the field, and certainly economic inflation. But a lot of this has been built into the system over the last decade and continues to accelerate as well. So what does this spend, what does this expenditure and this increase in health expenditure growth look like for our insurers? So for your employees, our employees, we've seen the average premium growth in 2023, so last year, was about 7%. Wage growth was about 5%. Over the past 5 years, we've seen premiums accelerate about 20%. Our deductibles are up 80% over the last 10 years. And despite all this, or in addition to all this, I should say, we've put about 100 million Americans in medical debt, and most of those have insurance. So one of the first pieces to look at is the Affordable Care Act. And like a lot of legislation, its name is more aspirational than factual. Certainly landmark changes that were extremely positive. It expanded coverage, expanded Medicaid to cover more lower income Americans, significantly got rid of pre-existing conditions. Some of you may recall that if you had a pre-X, you couldn't get coverage. It was much harder to get coverage, or you're rated up. And certainly, so these are massive changes, very, very important, that needed to happen. And of course, allowing young folks to stay on their parents' plan until age 26, and also eliminating the limits on coverage. So if you don't have to worry about if you have, God forbid, a challenging disease, having coverage that is limited. Those pieces are all gone. And again, really important. So who were the big winners from the Affordable Care Act? On our left, we see the share price of some of the major health insurance companies at the time, and currently, I should say. So at the time in 2010, this was our share price on the left. And moving over to the right, that's the share price as of late last year. So you can see the winners really, unfortunately, are these health insurance companies. And why? Well, they were given flocks and flocks of new members, and really a new, what we'll call a cost plus model with no ceiling, a new way of formulating their premiums. And that was essentially the medical loss ratio. So part of the Affordable Care Act was this thing called medical loss ratio. Really good intent. So it was intended to make insurers spend 85% of each premium dollar on medical care. So we're talking about, trying to make sure they're not overspending on admin, on executive salaries, profits, and marketing. And if they don't meet these numbers, then they have to rebate back to their enrollees. So, some good intent there, certainly. And there have been some rebating. But if you think about it, the carrier's incentive is to make sure they maintain those profit margins. So really the way to do that is to raise premiums. So if they have to spend 85% of those premium dollars on claims, they're going to raise those premiums to make sure that they maintain the profit margin that they want. And in fact, when we look back, we can see premiums have risen 20% faster since the MLR took effect. And we've seen some additional consolidation in the marketplace. So insurance companies buying pharmacy benefit managers and hospitals and provider systems so that they have the ability to make profits that are not capped by the MLR. The other large cost accelerant is big pharma, right? We all know about this. But we in the US here have a unique situation. We, unlike other countries, our pharmaceutical manufacturers have the unilateral power to set their pricing. So no price restrictions. They set their pricing. We did see the government, federal government, negotiate some most favored nation clauses during COVID for us. But other than that, for all the other drugs, it's up to the manufacturer. We're also the only country that allows pharmaceutical companies to manufacture or to market directly to the consumers. And our cost, the cost of our therapies is skyrocketing. We spend about twice what our peer countries spend on the same pharmaceuticals, the same medications. Humira, for instance, is about 420 some odd percent more expensive here in the US than in the UK. And of course, the pharmaceutical company, their argument is they've had to spend lots and lots of money to get approvals. They have a limited time to sell these drugs due to patents, and they invest heavily in research and development. Now, the flip side of that is if you look at what's actually going on R&D, big pharma spent more on marketing in every year than R&D since 1998. So not entirely true. So we have some estimates that McKinsey put out an estimate that there should be about 30 new gene therapies to be introduced in 2024. Hemgenix, which is a hemophilia drug, will cost about $3.5 million per dose. So a single dose, $3.5 million. And the question is, how are the insurance companies going to handle this? Does this high upfront cost pay off in the long run? Maybe it does. Certainly for that member, it would. But are we spending a lot up front and then maybe saving it as a system by removing that individual from all the chronic care that they need over many, many years by being able to access that drug? But at some point, we're going to have to figure out how to pay for these things, which are great. These are great revolutionary drugs that are coming on into the marketplace. Now, the federal government is starting to step in on negotiating some of these Medicare drugs that are covered by Medicare. So currently, they're starting the negotiation for 10 specific drugs and should wrap that up by the end of the year. So we'll see how that plays out. And they're doing that because the cost of the widely used drugs that they see flowing through the Medicare system starting to outpace the Social Security benefit. So about 40% higher cost of drugs. The drugs cost about 40% higher than what the average Social Security benefit is. So the federal government's stepping in to try and even the playing field. Now, from our side, we're a bit skeptical there. The pharmaceutical industry has 15 lobbyists for every other industry, so very, very powerful. So we'll see what happens over time. But our thought is really relying on the federal government to do this is not something that's going to work. And that's why Paul will talk about some of the things we can do to step outside of this crunch. Also, generics. Used to think of generics as a great way to access a lower cost version as a consumer. Well, that's starting to change. Generics are not always the lowest cost solution, the lower cost solution we expect, and that's for a couple reasons. Generics can take longer for FDA approval, which adds cost to those manufacturers. A regular drug takes around 8 months to get approved. Generic can take upwards of 42 months. So you're thinking, well, the R&D, there's no R&D cost to bring these to market, so we take that out of the equation. But there are other factors, like I just mentioned, and as these generic markets get smaller and smaller, so high cost to bring something to market, the cost or the price on that generic is quite low, so less opportunity to earn, right? So lower cost there, lower price point there, can reduce competition. Manufacturers simply get out of it. lack of competition raises prices. And then we've seen, unfortunately, some bad actors. We can see big pharmaceuticals buy up some of these generics. You might remember the case in 2015. Martin Scritley acquired generics to combat some a generic drug that combated parasitic infection. The day before they made the acquisition, that drug sold for about $13 a pill. The next day, it sold for $7.50. Currently, we have the DOJ also settling with 7 drug companies that made generics for price fixing. So a $681 million settlement that happened last year. So we have some bad actors. Now, when we think about this, we're like, okay, very, very high cost medications, driving our system, really one of the top accelerants in the healthcare system. We should have a transparent, easy process for getting these drugs, right? That would make a whole bunch of sense. We don't. This is a diagram of how a drug gets to a member. And right smack dab in the middle of this is an entity called a pharmacy benefit manager, or PBM. PBMs were really created in the 80s to serve as an admin role, ID cards, order processing, getting approved lists and formularies and pricing. Decades later, their role has expanded dramatically, and you can see there's about 6 different layers here that they control, and each of these layers are opportunities to add cost and, frankly, for them to add profit. And currently, 85-90% of all claims in our healthcare system are processed by PBMs. So close to 300 million Americans are on plans that are managed by PBMs. And then to put it even more stark, the vast majority of that PBM market is controlled by 3 entities: Express Scripts, CVS, Caremark, and Optum Rx. So, the PBMs will argue that they're getting lower costs because of their market share, their negotiation. But effectively, what's really the PBM is morphed into an administrator making kind of a cost plus and a dispensing fee to this very murky, multi-layered organization that adds a significant amount of cost into the system. And we are starting to see some movement at the legislative level to try and start regulating some of this. This represents the 32 buckets on the PBM where they can actually add cost into our system. So 32 instances of, as that drug moves through the channel, of a PBM being able to collect additional revenue. So things like spread pricing, keeping the rebate for themselves, maybe dispensing a 90-day supply but charging for 100. And then just remember that when I said a moment ago, those 3 big PBMs, they're actually owned or partnered with insurance companies. So Cigna bought Express Scripts. They spent $67 billion for that. United Healthcare owns Optum, CVS, and Aetna. So you start putting this together, and that's really shocking, and a reason why we're so motivated to help our clients and help the kind of the champion the going around this system, creating a solution that doesn't rely on a system like this. And the good news is we have some options. So 30 to 60% of all drugs of the transaction of a drug is waste. And there are pharmacy benefit managers, and Paul will talk to this here in a moment, that are credible. They don't play this game. They offer truly transparent services and pricing, and our members can switch to those. Right? They can switch to those kind of good actors and not have to go through this process and save a significant amount on their drugs without without losing anything, without losing access, which is obviously incredibly important. Things the other piece to this before I leave the pharmacy benefit manager and the RX component is, the sad part is when we're driving, costs are being driven up, when the cost of your medications are being driven up so high, you start seeing non-compliance at the member level. Kaiser ran a survey, and 3 in 10 said they didn't take the meds as prescribed because they're too expensive. So that means not filling a prescription. That means maybe cutting a pill in half, or skipping a dose. And ultimately, this type of behavior can adversely impact that patient and their health outcome, which adds even more cost into the system, let alone, you know, negatively impacting that person's life. A couple other pieces on cost accelerants. We are seeing some significant industry consolidation. And now, you might think that that creates efficiencies, which should lower some cost, but actually does the opposite. This has been happening for this last decade or so. It certainly was exacerbated by COVID. But when we stand here today and look at things, 40% of our markets have just one insurer. So no competition. The American Hospital Association reported close to 2,000 and 1,900 hospital mergers through 2021. And these numbers could be worse. In 2015, Anthem tried to merge with Cigna. Aetna tried to merge with Humana, but the Department of Justice blocked both of those. So, the other piece that we're seeing is private equity. Over the last decade, private equity has acquired and put in about $750 billion into the system. So that's taking over hospitals. And most of this was actually buying up physician practices. So, and the PE model, of course, is to acquire something, cut costs, and then raise prices. And actually, as we sit here today, the largest employer of physicians is actually Optum, with about 70,000 physicians. Our hospitals are also struggling financially. California last year issued a $300 million bailout to help these systems. Um, the labor cost, one thing that's really been hammering our hospital systems is labor costs. Post-COVID, lots of nurses, practitioners either retired, exited and went to a new profession, but there was a significant drain on nursing. And so hospital systems had to resort to staffing and temp agencies, which is extremely expensive. And a pretty grim picture if you look at it. Even back in 2022, half of the US hospitals ended the year operating at a financial loss. First quarter last year saw the highest number of bond defaults by hospitals in over a decade. Compounding this, these hospitals and providers lost that COVID bump. They were getting about 20% increase on their fee if that member, that patient had COVID. So that's been pulled, of course. And in addition to that, our insurance companies have significantly increased the administrative burden, making it difficult or harder for these providers to get paid. You'll see, and you might hear some of your members and employees complain about prior authorizations. There's been a flood of those. Those are steps that a provider has to go through for expensive care. But those are also coming into areas like MRIs, pretty routine things. And 50% of all prior authorizations are overturned. So it's mostly an unnecessary bureaucratic step that adds cost into the system and really helps hurts that hospital system or that provider by dragging out their payment. So we would hope to have some price transparency, right? We'd be able to shop. We talked about, I'm sure a lot of you know about health savings accounts, consumer-driven plans. Those have been very popular over the last decade. Pretty hard to be a consumer though if you don't know what the price is. So we're in this position as consumers to make a medical decision, a care decision, which obviously we're going to always rely on our physicians, but we have no tools, no resources to know what that's going to cost, no way to shop amongst health systems. It's a bad place to be. So the federal government has tried to encourage that. So in a positive direction, we saw some rules come out requiring insurers and group plans to publish some price information, as well as same with hospitals, making hospitals and providers have to publish on their websites what they call machine readable files, so some price information. Unfortunately, this isn't something that the providers really want to do. As of April of last year, the CMS had issued about 730 warning notices for noncompliance. In a survey of 2,000 hospitals, only a quarter of them were doing this. So hospitals, by and large, haven't been complying with this. And when they do, it's very difficult to make heads or tails of these machine readable files. And even if you can, then it's even more difficult to compare the cost of a surgery from one facility to the other, because we don't know, one facility may bundle a bunch of things in it that the other facility does not. I will say that there's a company called Turquoise Health that does a decent job. You can go on there and they will basically use their AI and algorithms to pull those machine readable files and discern down usable information so you can do some price comparisons. So from a benefits perspective, you know, where are we now? We're really in this vicious cycle. So we have all these accelerants on price hitting the system, hitting the healthcare system. And we don't have the tools, we don't have the transparency. And at the insurer level, most clients of mine and tend to be fully insured, right? They're in that traditional approach, and I'll explain that here in a moment. And we see the inclination to really just move at renewal to maybe a new carrier or change the plan, put more cost on the member. That's unfortunately that's just not going to do it, particularly moving forward when you have these really gale force headwinds from cost. So we are in this, and without transparency and data, you don't have much of a chance other than that. But we feel that may work for some. But in terms of setting up a strategy, we want to look at it more as managing a supply chain, right? We want to deliver an effective, consistent, um, robust benefit package, but we also want to manage that package as we would something that costs, is one of the costliest things on our balance sheet. So how do we do that? Currently, as I said a moment ago, um, most firms will just transfer that risk, right? That scale on the left. They'll just transfer all that risk. They will pay the insurance company premium, and that's that. As we move forward, what we really like to see is assuming some of that risk, mitigating that risk, extracting data, right? So we know how to plan moving forward, and then managing it, really looking at the entire value chain to identify where risk can be balanced in a way that provides protection while also maintaining control. So as I mentioned, the fully insured, there's a couple of different models. So I'm going to talk really quickly before I turn it over to Paul of this fully insured, and then something called level funded and self-insured, or really alternative funding. Most are very familiar with this. It's what most of us are doing right now. It's that fully insured retail. You purchase from one of the big carriers, Anthem, Aetna, Cigna, et cetera. I understand everyone hates their insurance company, but they hate leaving them even more. But we're now starting to see in this marketplace some outsized renewals, some 30s, some 40% increases on those larger employer plans. For the ACA plans, so for smaller employers, typically starting to see, used to be in the single digits, low single digits, we're starting to see those ratchet up 10, 15%. But again, you shift the risk. It's 100% of the fixed cost. You just pay your premium. Downsides are there's no data, no real control. There's no real risk. You're certainly not financially at risk. The caveat there is it's pretty difficult to manage something when you get a renewal or a proposed increase of 30% on a large number 3 months before you have to make a decision. So there's no real planning there, no ability to plan. When we talk about starting to build a solution and reimagining things, really talking about some of these alternative fundings. One of the ways is level funding. So I'll talk about that here in a minute. That's really dipping our toe into this alternative funding pool. Self-funding, some of you are probably pretty familiar with this. It's not necessarily self, but this is really jumping in. Your 40% of your costs are fixed, so that's the premium you pay towards the parties that you're in, the fees or premium you pay towards the parties that help you run this program. And then 60% is variable. That's going to be your claims. And that's really where we can make the most impact, and deliver not only cost savings, but also gather that data and deliver a better plan and experience to our members. This is just so for the self-funded plans, you're really shifting some of the risk onto the employer. governance and um, statutory things that we have to comply with is really at the federal level instead of state level. And then we're really talking about unbundling the fee, so taking the premium and shifting it to a fee approach and taking that apart. Um, so the good news here is we certainly reduce costs. We can get a cash flow lift when we transition into these programs. And most importantly, we're getting actionable data and the ability to control. Now, downside folks will say, well, you are taking on risk. Of course, we can mitigate that. And some will say that these programs can be volatile, but that's also something we can mitigate as well. Well, how do we know if most of us are in fully insured and we have no data? How do we get into self-insured? How do we go to a program where we're shifting all that risk? Well, one way to do that, certainly we have AI tools now that we didn't have before to scan our census and make some pretty accurate projections. But there are programs that allow us to sort of dip our toe, as I mentioned, and that's level funded. That's where our insurance carriers, with the insurance carriers, will take your data, take your plans, look at and really make their best guess, their actuarial analysis. I should say not a guess, but their actuarial analysis of your membership and set a fixed premium. That's why it's called level. So there's no real risk on that. You're paying that fixed premium every month, just like you would on a fully insured. And if the plan runs better, so your claims are lower than projected, you have a surplus. You can have a surplus that you get to share in. If they run higher, you don't have to write a check. You're not liable for that. It just gets baked into your next premium. So it's a nice way to get up and running. It allows you to get data. That's probably the most important piece here. Is you're going to get a lot more data. You're not going to get all the data that you would want, but you're going to get a lot more data. Really going from black box, no data to something that gives you quite a bit of data that can be utilized to then maybe transition into something that's a little more custom. The challenge with these programs, before I transition to Paul, is it's kind of like a casino. The carrier is still involved. They're always going to win, right? So even if you have a surplus, they're going to take part of that surplus. And sometimes it's pretty sizable, 50% or more. So, and if you perform well, I should say, in this program, pretty good likelihood you'd perform well in our alternative funding or our self-insured. So we're not going to get into all the ins and outs here. I'm going to turn over to Paul to talk about what we're doing from a custom approach and how we really do take it to the other level in reimagining benefits through a custom plan.
All right. Glad to be here with everyone. I would say there is good news. You do have all these pressures on price that Reed has talked about, and I don't want you to get the impression that that there's nothing you can do about it. There certainly is, and it's a growing subset of employers that are doing something about it, and they're outperforming the market. And the other thing I would say as we jump into this is that we have a really smart team, a really great group of people, clinical people on our team that are medically trained, that are also data analysts that contribute to what we're sharing with you today. But we're not so smart that we invented all this stuff. I would give credit to Tom Emmerich, a guy that ran Walmart's plan for quite a few years. I actually worked for one of the insurers that had some of their business while he was there, and he came to all of us and said, look, this isn't working that well. We seem to give you more money every year and get less coverage for our employees. And he was in a self-funded plan at the time, and he wasn't, that alone didn't necessarily solve the problem. He had access to claims data, but he wanted more transparency and the ability to have more control and influence over the outcome for his plan and for his employees. And he made some demands around transparency. And our whole approach to this problem is to get those same vendors involved in our clients' plans. And we'll talk a little bit about that as we go forward. But for that reason, when I look at this over the years, I've figured out, having looked at a ton of different plans, literally thousands of plans, you could have a plan in just about any funding arrangement that is overpaying for services or is subject to a significant amount of waste in the cost of the transactions. When somebody gets a prescription, or when a member in the plan gets a surgical procedure, or an imaging procedure, or lab. So not just the funding arrangement that's going to fix the problem. Some folks on this webinar may have made a change from one funding arrangement to another and said, look, I made a change and I still see the trend line has the same kind of curve into the future. What can we do about that? And that's what we'll talk about now. Is we call it building a custom plan. That's where you get these right vendors involved. You access the best possible contracting where that's the issue. And what we end up doing or having is this smart group of people that I mentioned, they look at the two buckets of money that make up every health plan. You've got a small bucket of fixed costs, 20 or so cents on the dollar, and a big bucket of claims. There are opportunities to lower costs in that smaller bucket, those fixed costs. And it's probably around 5 points. Many of you on the call have probably had the experience, probably more than once, where you got your renewal from the insurer and they said, hey, we need an additional 20 points this year. You said, hey, that's too much. It's out of line. And it magically came back at around 15%. I can tell you from working for insurers that we would give our underwriters underwriting discretion to accommodate kind of the feeling of negotiation around that renewal. And which really was another way of saying we kind of came in a little bit high each year. Some likely confirmed your suspicions around that. I'm not saying you shouldn't go through that dance, even though there's a little bit of an element of theater to it. You should, or you'll overpay by 5 points. But the more powerful thing is to look at the bigger bucket, that 80 cents on the dollar, the claims, and see what you can do there. And that's where the big opportunities are. And in order of magnitude, it's in drugs, hospitals, and surgeries. And we'll give you a couple quick examples of the kind of things you can do if you build a really high-performing plan to get better outcomes. I'm going to just, regardless of what the slide says, I'll talk real quickly about drugs. Reed mentioned earlier that you've got these pharmacy benefit managers that are middle players that are adding a lot of cost. When we analyze that part of the business, because every plan, you end up with two categories of claims: drug claims, RX claims, and medical claims. And when we look at those drug claims and we pull out a single drug transaction, 30 to 60% of it is often waste. That's the bad news. The good news is waste, meaning fees attached by the pharmacy benefit manager who did not make the drug, wholesale the drug, or retail the drug. Good news there is that you can fix it. There are about 300 pharmacy benefit managers in this country. Not all of them are credible. About 60 of them are credible, is what we would call it. Credible to us means you could take one out, put another one in, and it wouldn't disrupt your people's lives. They could continue to have access to all the pharmacies and all the prescriptions and all the drugs in the market. And what we end up doing is on a frequent basis, we do large-scale repricing with that group of 60 so that we can look at our clients and prospective clients with confidence and say we know who the top performers are at any given time. And that's a shorter list of 5 or 10. And to get on that list, a couple of things need to be true. One, they need to be willing to go back to the original revenue model that they all used to have back in the 80s when this all started, which is a per script fee as their only source of revenue. And then they also need to be transparent. We should be able to take out a drug transaction, break it down, and see where all the money went. When we do that, it's not at all uncommon to reduce the drug spend inside of a health plan 30 to 50% without reducing access to the drugs. And another very positive outcome of that process, a very common outcome for us, is that your members can end up with no copays for high dollar brand and specialty drugs in that process. You drive so much savings in the cost of the drug transactions that you can create a much better experience for your employees and their families. And it's another last kind of important part to that is that you can, by getting the drug inflation under control or the waste out of the cost of the drug transactions, you're making a big step forward in controlling the future increases that your plan will face. Drugs are the most inflationary part of our business, as Reed mentioned. If we can get those under control, that's how we can get to a better trend line into the future without having to continue the process of giving up a little bit of benefit each year for your members. We can look now across thousands of employers who have been trending slightly below 3% a year. And when you compare that to the overall marketplace, that's about half of the national trend. So those are some thoughts on drugs. When it comes to the medical claims, they're all all kind of solved the same way. So it's about claims management and contracting. So I'll use this specific example, surgeries. It's kind of a little bit of a funny one because I'm the living example of this slide. I figured during COVID, since I stopped flying 45 weeks a year, I'd buy a kettlebell off the internet, teach myself how to use it on YouTube. So I gave myself a hernia, and you see one 4 down on this slide, you see there's a hernia repair. And so I got to experience firsthand how these plans work that we build for our clients. And as a feature of our plan, Reed mentioned earlier that one of the challenges we face is that consumers don't have good information to consume. You have to fix that if you're going to get a better outcome. And most jumbo plans do and have for many years. It's one of these things that we're bringing down market for our clients. So as a feature of the plan, I was able to talk to a nurse. I'm in Nashville. And the nurse said, okay, here are the 3 top surgeons in Nashville that will do the procedure that you need, meaning they have the best quality scores, the best outcomes. And if you use any of these 3, you will have no share of cost. Really great news to me on both counts, quality and cost. I wasn't restricted from using my health plan the way that I may have in the past, but I had that added ability and reward to work with a nurse advocate. And you see the 3 columns there. If this was true to life, one of the most shocking things I've learned in the last 15 years in this business is that a typical facility has more than 150 prices for every procedure they perform. It's pretty crazy. But just to kind of, for illustrative purposes, we've condensed it down into 3 columns. But you see on that right column, there's a cost just a little bit below $5,000. That's what our plan paid, which is why the plan was able to come out ahead and still waive my out-of-pocket costs. So a win for the plan and a win for me as a member. And that's the goal that we have with everything that we do, is that it benefits both the plan and the members. This is another good example. LA Times did an article on this. They called all around the country and said, what would you charge cash for a CT scan? And the average answer was $287. And then they said, well, what if I pull out my insurance card? And it became obvious that there's really ends up with, out of that 150 prices that exist for every procedure, you really can break it down into 3 categories of payers. If you have Medicare or Medicaid, the providers tend to lose money on those transactions. If you show up and your card is attached to a really jumbo employer plan, that plan ends up paying cost plus reasonable profit. And if you're everyone else, you're paying that highest amount for that procedure. And in that article, it was mentioned that the math became pretty obvious. They would take that cash price, add a 0, and then apply your discount if you were in that kind of that 3rd category of payers. That's what we're looking to solve for. And you can do it by accessing better contracting and managing your claims better. And it doesn't have to do, it's not about undercompensating providers or creating a transaction with a loser involved, which I don't think is a sustainable model. It's about actually being a better partner in the transaction. Reed mentioned earlier, we've got 100 million Americans in medical debt. Most of them have insurance. They just slow pay or sometimes do not pay their share of cost when they have a procedure. So we've put providers in the chase money business, and they end up writing off a lot of that on an annual basis. So if you as a plan were to go to those providers and say, look, we'll pay in full at the plan level. You won't have to chase our members for $1, and we'll pay promptly, week of service. You've solved 2 of their big problems, slow payment and no payment. And that can make better contracting available. Another way that you can improve the performance of your plan is to manage the formulary properly. And that list of drugs that people have asked you, there are things that we call stupid drugs. You see it in quotes there, which is a little bit in jest, but there are drugs that are available on the over-the-counter market, literally for a few dollars, $8 and $28 in this example. And in some cases, they'll simply combine those into one pill and then put them on the formulary and charge the plan literally thousands of dollars. Why do they do this? Sadly, it is because they can, and they're driving a ton of profit from doing this kind of thing. So when you run your formulary well, you keep an eye out for this kind of thing, and you don't allow that type of abuse to go on in the plan. There's a bunch of different funding arrangements out there. I mentioned the idea of retail plans versus custom plans, and the funding arrangement, it can be anywhere in there. But one of the things that you'll hear a lot about lately, I think in the last few years, it's gained a lot of momentum, is captives, and they can be a very good option in terms of funding arrangements, so long as you're doing some of the other things we talked about to use that data and transparency that you're getting and that control to actually impact the cost of what your plan is paying for services. So long as you're doing that, another way to buffer your plan based on your size, for those that are maybe in a smaller employer environment, a captive can be a smart way to go, or at least something worth considering, where you can band together with other like-minded employers to level out the volatility in your plan. And this is an example of a kind of a high-level analysis that our clinical team did and can do. It's something that our team does at no cost with some basic data about a plan. They can look at that plan and say, here's what we believe is possible if we were to apply some of these concepts to this plan or to your plan. And in this case, this employer had a retail plan with Aetna, and their trend line was that upper blue line. After building a custom plan, which by the way was also with Aetna, they were able to outperform that green line that was projected, and they ended up outperforming that bottom right number in terms of what they recovered for the organization, while improving benefits, doing some of the things we talked about in terms of eliminating co-pays for drugs and other medical services, surgeries, imaging labs, etc. So I think good thing to quickly mention is that it's about not buying healthcare 1 year at a time anymore. If you've been at this any length of time, in any 1 year, it's not necessarily catastrophic to approach this as a 1 year buying decision. You might see costs rise if you're running with national averages, 6% a year for many years. That also includes giving up some benefit in most cases. But if you look at it over a stretch of time, over a 10-year run of time, we've seen deductibles grow 87%, premiums more than that, and a ton of medical debt created. And some of those folks are your employees. So how do you get out of that cycle? And that's to put together a multi-year plan where you take control. Taking control is really starting to get data. And in some cases, like Reed mentioned, that could be as simple as getting into a carrier-based level-funded program where you can start to see what's going on in your plan, other than the limited amount of information they might share with you in a fully insured retail renewal. Then you take that data and work with someone who can put a strategy together based on your data. Here's what the data is telling us. The data should drive decisions and long-term planning, and then you can get to a place where you're managing that in real time, and you have a lot more predictability, and you have the ability to control costs and improve benefits over time, and be in that top quartile or quintile of employers that have richer than average benefits, but are also in the lower quartile of cost and trend.
I can talk to, I'll talk to this just quickly, and I know we want to leave some time for questions. Thanks, Paul. One of the other strategies that we've started to see, and some of our clients have accessed, and some of you on the call may have gone through this, is a PEO, so a professional employer organization. It's a large market. It's been around for decades. It's growing of late because of these cost accelerators. And this is really a co-employment, typically comes through payroll companies like ADP or TriNet or Paychex, Insperity. Those are the big ones. And effectively, they co-employ your employees, which gives your employees access to their health benefits. So really, it can take a smaller firm or company, have them join this larger ecosystem and get access to, say, Fortune 500 or AmLaw 100 styled plans that are composite rated, so no age rating, and bring aboard quite a number of other services as well, some HR support, technology, multi-state compliance. So they can be a nice solution for the right employer to try and manage their healthcare spend. These are typically positioned as a healthcare play, even though they are a payroll solution, a HR solution. I will say that so they can be right for some, certainly, and that's why we wanted to at least touch on it. You are still in a fully insured environment, so you are not going to get data in these programs. If you perform poorly medically, you can get large increases. Even though they have this large pool, they are paying attention and they value that pool. So if you're unfortunately one of the ones um, that isn't performing well, you can get outsized renewals. And they can be a little bit difficult to unwind because you are bundling everything typically. Maybe you can carve a few things out, but typically bundling everything with them. But wanted to at least mention it as you may see these, you may come across them or you may be approached by them if they're running your payroll currently. And I think with that, we've got a few minutes here that we can open up for some questions if folks have them.
Okay, perfect. Thank you. So we do have a few questions here, starting with this question is from Cynthia. Are alternative funding plans available to small groups? We currently have 11 full-time employees on a traditional insurance plan.
I'd
Short
say,
answer is yes.
yeah, there you go. Size does affect options, but you do have some options at that size.
And I'd say particularly on the captive side, so there are captives that they like that risk. They think they can better manage that risk. So yes, particularly as well on the captive side, there should be some opportunities.
Okay, thank you. And how does the cash flow predictability differ between a fully insured retail health plan versus a custom alternatively funded plan?
So I can jump in on that. Years ago, and I think the belief persists, even though it maybe doesn't need to as much as it used to. It used to be true years ago that if you made the transition from a fully insured retail plan to an alternatively funded plan, you also had to be prepared for cash flow volatility. And if you were 2 months into that plan and someone in your group got, God forbid, diagnosed with a big cancer diagnosis, then you were going to have to inject a large amount of cash into that plan to deal with that. And there's been a lot of evolution in the reinsurance side of the business over the last decade, so that that isn't the case anymore. Virtually all the plans that we build, in fact, even Walmart isn't truly self-funded anymore. I would say at best, partially self-funded is probably the most accurate description of where they are, and most end up that go down this road. But level funded is probably most accurate for those on this call. That not that it has to be a carrier-based level funded plan, it still could be a custom plan. But in the way that the cash flow works and the financial mechanics are set up behind the scenes on the plan, every plan that we build, you can begin the plan year knowing this is what my liability is for the year, this is what my monthly expenses will be, and you can budget for it with the same predictability that you enjoyed historically in that fully insured retail plan.
Thank you, Paul. How is the member experience different between a retail plan and a custom plan?
Well, you have a lot more control there and flexibility on and kind of the tools that you or the programs that you choose to integrate into the plan. But at a high level, what we've seen over time is that everyone, for the most part, everyone hates insurance, but they hate change even more. So we're careful with that. And if you roll things out in a plan, I mentioned my own example earlier with a surgery that I needed. I had the option to engage with a nurse advocate and get some rewards for doing that, which benefited me and it benefited the plan. But I also continued to have the ability, in the way that our plan was designed, to access healthcare in the way that we all have for decades. So long as you build the plans in a way that makes additional information and services available to your members, and you're not doing it in a way that makes them feel like you're taking things away, then you end up with an improved member experience.
Thank you, Paul.
One of the things I'll just add there too is in a custom plan, typically when we're going out to renew those plans, the piece we're looking at is really on the back end. So we're talking about stop loss carriers and there's 40, 50 of those that we can market to as opposed to five, in the traditional market, right? There's a set amount of real carriers. So what can occur is we swap out the back end, the member experience, their physician networks remain exactly the same year over year over year over year. So we get out of that cycle of where we're at today, which is at some point we have to switch the entire dismount and reboot the entire platform with a new carrier. So that is, in my estimate, having gone through many, many, many of those with our clients, that's really disruptive for the employee. Even if you're going from one major to the next, they're resetting their prior authorizations. They're getting step therapy, potentially having to redo all that. On the custom side, we're really mostly swapping out the back end, that renewal.
Thank you, Reed. If we were to move this direction, would our plan still use one of the major networks?
Yes.
Yeah, simple yes on that. I would add just a quick thought to that. 2 out of 3 people that have a Blues, United, Cigna, or Aetna logo on their card are actually on an alternatively funded, custom-built plan with consultants involved, and they don't even realize it. They just tend to work for a larger employer. But I think keeping those big brands involved is important so that members feel like they have a quality benefit.
Thank you. It looks like we have time for one more question. I don't want to present something that you've answered already, but just in case, we already have a self-funded plan. What is the difference between a self-funded plan and a custom plan, as you call it?
Yeah, I mentioned earlier, I touched on it probably a little bit, but it's a good thing to reiterate that really what the difference maker isn't the funding arrangement in and of itself. The funding arrangement can give you access to more data and the ability to have more control, which is critical. But if you don't use that data to your advantage and you don't take control and then use that data to drive good decisions and picking their best in class vendors, say the best pharmacy benefit manager for the drug benefit as an example, then your plan is likely subject to the same amount of waste in a transaction as when you were fully insured. I've had some very savvy CFOs and managers talk to me about the fact that they had a fully insured plan and then they had a self-funded plan, and when they looked at the overall cost, they ended up being similar. They were just prepaying or maybe paying as they went. And I thought that was a pretty accurate description of the change if you don't go to the next step and really customize the offering and go into some deep analysis of the contracts and the vendors behind that logo that really drive the results in that plan.
Perfect. Thank you. That's all the questions that we have for today.
Thank you very much for the time. We certainly appreciate it. Hopefully this was helpful. And again, thank you. Hope everyone has a great Valentine's Day tomorrow. Thanks again.
Have a great day.
Thank you both, and thank you to ALA. Thank you all for attending. Thank you to today's sponsor, Acrisure. This concludes today's webcast, so thank you again for attending. The recording will be available later today. We will send all registrants an email tomorrow with this link. Please visit our event